All right, exam day is breathing down your neck, so we are not wasting a single second. This is your super fast, high-yield review of adult congenital heart disease. We're going to hit everything you absolutely need to know and nothing you don't. Let's do this. Feeling that pre-exam heat? Good. Let's use it. In the next couple of minutes, we are going to nail the most commonly tested ACHD topics so you can walk in there tomorrow and just absolutely crush this exam.
First up, challenge number 1, the shunts. Now listen, the whole game here is figuring out where the oxygen saturation steps up. If you can spot that one clue, you've got the answer. It's that simple.
So let's start with the atrial septal defect, the ASD. It's literally just a hole between the left and right atria. But what you really need to know are the classic exam clues.
Here it is, the money shot. The cath finding is a saturation step-up in the right atrium. That is your dead giveaway that oxygenated blood is spilling over from the left side. So if you see RA step-up on your exam, your brain should immediately scream ASD. Oh, and don't forget, secundum is the most common type.
Moving on, we've got the ventricular septal defects, or VSD. This time, as the name suggests, the connection is down between the left and right ventricles.
Okay, so you see the pattern here, right? Where's the step-up going to happen this time? In the right ventricle, of course. You've got high-pressure, oxygenated blood pushing from the LV straight into the RV. So your cath finding is an RV saturation step-up. See? The location of the hole tells you exactly where the step-up is.
And our last shunt is the patent ductus arteriosus, the PDA. This is just a leftover connection from when you were a fetus, linking the descending aorta directly to the pulmonary artery.
By now, you know the drill. Where's the shunt? Aorta to pulmonary artery. So, where's the step-up? You got it, in the pulmonary artery. Let's say it together. ASD is RA, VSD is RV, PDA is PA. Burn that into your brain.
Okay, challenge 1 is done. Time for the first boss battle, Tetralogy of Fallot, or TOF. Don't let the name scare you. It's just 4 specific defects that you absolutely have to memorize.
Here they are, and this is non-negotiable. Number 1, a VSD. Number 2, an obstruction in the right ventricular outflow tract. Number 3, because of that obstruction, you get right ventricular hypertrophy. And number 4, an overriding aorta. You have to know these 4 cold. And this leads to a super common question about what happens after surgery. How do you follow these patients? The answer they're looking for is MRI. It's the gold standard, the reference standard for checking out the RV and seeing how bad that pulmonary regurgitation is. Remember that, post-repair TOF equals MRI.
Awesome. Let's roll into our third and final challenge before we hit the final numbers round. We're talking abnormalities of the great vessels, and we're starting with a real classic.
This is coarctation of the aorta. The easiest way to think about this is a pinch in the aorta. And what happens when you pinch your garden hose? Exactly. You get super high pressure before the pinch and really low pressure after it.
And that gives us the hallmark sign you have to know, upper limb hypertension. The blood pressure is high in the arms but low in the legs. The body tries to get around this by growing these extra vessels, called collaterals. That's a key imaging finding. And for the MRI nerds, a diastolic tail is that classic sign of a bad coarctation.
Next up, transposition of the great arteries, or TGA. Look, this slide says it all. The plumbing is just plain wrong. The aorta is hooked up to the right ventricle, and the pulmonary artery is hooked up to the left. You end up with 2 completely separate circuits that don't mix. Without some kind of shunt, this is fatal. You made it. Welcome to the final boss. This is a rapid-fire round of the critical numbers, the thresholds that tell you what to do. Knowing these numbers is often the difference between getting a question right or wrong. You ready? First number, acute to Q's ratio greater than 1.5 to 1. All this means is that way more blood is going to the lungs than to the body. If you see this number, it's a class 1 indication to go in and close that shunt, whether it's an ASD, VSD, or PDA.
Next, a QRS duration over 180 milliseconds. In a patient who's had a TOF repair, this is a massive red flag. It screams high risk for sudden cardiac death, and it means you need to be seriously thinking about putting in an ICD.
Okay, now for those TGA patients with a systemic right ventricle.
If that RV starts to fail and its ejection fraction drops below 40% and the patient is symptomatic, that's your class 1 indication to replace that failing tricuspid valve. You can't let that systemic RV go down.
And one last number for you, an RV end systolic volume index greater than 80. This is the magic number for considering a pulmonary valve replacement in a post-TOF repair patient who feels fine, who's asymptomatic, but has severe pulmonary regurgitation. This tells you when to step in before they get sick.
And that's it. Gauntlet complete. We just tore through shunts, tetralogy of Fallot, the great vessels, and all the critical management numbers. You've got the high-yield facts locked and loaded. Take a deep breath. You've seen the patterns, you know the numbers, you've got this. Go in there with confidence and show them what you know. Good luck.